Hi everyone, this is Gina Herrera again. I'm going to give the lecture called Labor Part 3. It's part of that intrapartum concept of lectures, and this is titled The Delivery. So we're going to go over the delivery, different types of risk factors for deliveries, as well as a normal labor and birth that the patient will experience. So let's kind of review a little bit what we kind of had talked about maybe the last lecture or two. Monitoring labor progress. So how do we do that? Of course, we're going to look at the stages of labor, and we're going to, decide what stage or phase, because the first stage actually has 3 phases involved: the latent, active, and transition. The second stage, the third stage, and actually there is a 4th stage. Again, it is from the delivery of the placenta to the first 4 hours postpartum. We look at maternal behaviors, and of course, the cervical exams tell everything about where we are with the stages. So those cervical exams, we're assessing for dilation, station, and effacement. So cervical exams, you might see SVE, sterile vaginal exams. We look at dilation, effacement, and station. So the dilation is how open that cervix will get. And it can go from closed to 10 centimeters. That is, one big thing people always ask, how much are they dilated? But there's other things too that tell us about the progress of the labor, and that would be the effacement. And the effacement is how thin that cervix gets, because the cervix is pretty thick. It's a thick tissue, and it thins out like paper thin. The thinner it gets, the more it's expressed in a higher percentage. So 100% effacement is paper thin, where if it's just 20% effaced, it's still thicker and it's still kind of long. That cervix shortens and thins out as the labor progresses. So we look at the effacement. The station, again, remember, we have that, I always say, compare it to a math line, where you got positive numbers on a plane and negative numbers on a plane, and 0 would be neutral. Well, the descent of the presenting part, we use the ischial spines as our landmark. It's measured in centimeters. So if the ischial spines is my landmark and my presenting part is at the ischial spines, we consider this at 0 station. So if the baby's higher than the ischial spines, it's in a negative plane, and it goes -1, -2, -3, -4 is really high, okay? If the baby's presenting part is below the ischial spines, it's +1, +2, +3, +4, the baby's out, okay? So we got to think about that again, that negative plane, that positive plane, and that neutral plane being those ischial spines. If that presenting part is there, then we consider that 0 station. Here's some figures of what dilation actually looks like. So 1 centimeter to 10 centimeters. The effacement and dilation, again, plays a big part with those exams, those sterile vag exams, because the more thin the cervix gets, it effaces, the more likely it's easier for it to open and dilate. With a multigravida, remember, this is someone who's been pregnant before, they efface and dilate concurrently. So it's a little bit quicker than the primigravida. The primigravida, they efface 50% before labor even starts. And dilation will take longer because the cervical tissue have not been stretched before, because again, this is the first time that they're going to deliver. So the cervix has never been through any of this before. And you can refer in your page and your text to page 190, and it's figure 7-2. This kind of gives you a little bit more of an understanding of the effacement and dilation. But as you can look at the pictures, the primogravida, you can see where it's thicker and longer as opposed to the multigravida. And you know, that's because, again, the multigravida, their cervix is just going to kick right back in where it left off with the last delivery. So keep in mind, it is a little different for each. This is a way we can express it. 5, 90, and plus 1. The cervix is 5 centimeters dilated. The cervix is 90% effaced, and the station is at plus 1. So you might see it expressed this way in the chart. Effacement again, you can see where the not effaced picture, it's long, it's thicker, and the effacement, it shortens and it becomes more thin. So this is just, again, another diagram that you can look at for effacement. The speculum exam or sterile speculum exam may be performed if the patient is preterm and they're uncertain about rupture of membranes or to obtain specimens. So we don't want to put fingers in the vagina. First of all, you can stir up things and cause dilation to occur. You can also possibly risk giving the patient an infection actually to the baby. So if they're preterm, it's usually a speculum goes in and it's a visual exam. The doctor or the practitioner will look at the cervix and decide if it's dilated or not. Not so much going to be exactly as if you would have put fingers in there, but we, again, being preterm, we don't want to put this patient at risk for anything. So we look at the vagina and the cervix through a speculum. So dilation, we look at that. We look at the presence of any fluid. So if we're determining if her membranes are prematurely ruptured, you might see a pooling of fluid in the vagina right by the cervix. If there's any blood or indicators of infection, we can also observe for that. And there's some, fetal fibronectin is a type of test that we can do, and PG testing. That's all testing that we would take the fluid and check to see, again, if those lungs are mature. Assessing rupture of membranes, so SROM versus AROM. So what is SROM? Spontaneous rupture of membranes. The water bag breaks on its own. It just pops, okay? A gush of fluid comes out. Mom could be in the department store standing in line, and all of a sudden there's a pop go on, and there's a pool of fluid around her feet. So, it's not unlikely. It can happen anywhere, and it's spontaneous. So we never know when it's going to occur. So artificial or AROM, artificial rupture of membranes, is when they artificially go in. And they use this thing, it's called the amni hook. It's the picture on the right, the top one. And it's got like a little, it's kind of got like a little hook on the end, and it's kind of sharp. And what they'll do is they'll go in, and the practitioner or the doctor will feel around to get to the water bag. And once they feel the membranes or the water bag, they put that little needle and they kind of snag a little bit of it to see if they can pop it and artificially rupture the membranes. One big thing, whether it's spontaneous or artificial rupture, you want to note the time, you want to note the color of the fluid, the consistency. Is it thick? Does it have that pea soup consistency, or is it thin? When we look at the time, going back to the time, a patient cannot be ruptured no more than 24 hours, and if they're term, and not be delivered. Sometimes our preterm patients come in and they're ruptured, but depending on the outcome of the baby and the survival, we may keep them in Trendelenburg and give them antibiotics to, every day that the baby stays in utero is like important. But on a patient that is a normal, not a high-risk patient that comes in labor and she's not preterm, if she told me her water bag broke at 6 o'clock this morning, then we have till 6 o'clock tomorrow morning to get her delivered. After 24 hours, there's a risk for an infection called chorioamnionitis, where the patient can get a really bad infection. Okay. The color, again, it can be clear. It can have like little white particles in it. It could be greenish. It could be yellow. It could be, different colors, but the color, especially if it's the green or the yellow, that could be meconium. So when the baby's having some distress at some point while they're in utero, they will have a bowel movement in utero, and that's why the fluid comes out that color. We hoping that it's clear, but sometimes, again, those things happen. Knowing that at delivery, we want to make sure that we have suction available, that the doctor can go down and suction, or the nurse practitioner from NICU will come in. I know at Lakeside, whenever we have a meconium stain fluid, a patient that ruptures membranes and there's meconium, the doctors would like, and it's kind of protocol, that the NICU or the nurse practitioner from NICU is present at the delivery, that she can go in and look below the vocal cords and make sure that the baby doesn't aspirate that meconium fluid, because it can cause a serious bacterial infection of the lungs. So we look at the color. The consistency, it can be, really watery. It could be really thick, like a pea soup consistency. Again, green pea soup is that thick, nasty meconium. And I know we talked about amnio infusion in the other lectures, where we can kind of water it down and thin it out. It's easier to suck out fluid out of the lungs that's thinner than opposed to the pea soup consistency. So it could have particulate in it, like, chunks of meconium. So again, we have to note that as well. The odor, if it has a really strong pungent odor, that could indicate infection. Usually it's kind of a sweetish smell. It smells kind of sweet. There is a distinct smell for amniotic fluid. I can't explain it, but you just kind of know what it is. But again, if it's a foul odor and it's a pungent odor, then definitely we start thinking maybe mom might have some kind of infection. So how do we determine if mom comes in? Because again, sometimes at the end of pregnancy, there's so much pressure, you feel like you just kind of can leak urine every once in a while, and they may not know the difference if it was maybe a little bit of fluid leak out, or was it urine. So better safe than sorry. We always tell moms to come in and get tested. So we can use a paper. It's almost like a litmus paper, but we call it nitrazine paper. And that paper will turn dark blue if it is amniotic fluid. If it's not amniotic fluid, it stays yellow. It's like a yellow paper. We can also do the ferning test, which they take a little bit of the fluid, so it'll go in with a speculum. They'll ask the patient to do like the Valsalva or cough, and from doing that, the fluid will pool in the vagina. They'll take a little swab and they'll dip it in the fluid, and they'll smear a slide and look at it under the microscope. And it appears to have a ferning pattern, like a fern, the plant. So it looks like fern leaves under the microscope, and that would be indicating that that truly is amniotic fluid and that the patient is probably ruptured. So there's different ways that we can do that. But these are all things that you would, again, document with that. Management of discomforts of labor. So there's non-pharmacologic comfort measures supporting them, position changes. Sometimes they'll use it's called a peanut ball, where we put that between their knees to help open the pelvis, and kind of we do that while they're on their side. Of course, you don't want to leave them flat on their back. Massage is really good if you have somebody, a good coach with you, or a significant other that is definitely into the whole process, to massage the back. Hot and cold compresses, because remember, those contractions start in the back area and they usually come to the front. So, you kind of want to work on that sacral area. Hydrotherapy, some hospitals provide birthing tubs. And it's kind of like you can labor and get in the tub. It's not a hot tub, but it's just a birthing tub. Rhythmic breathing, like Lamaze, focusing, visualization, finding something in the room and just kind of zoning in on it and just breathing and just kind of getting through the contraction. So if this person is not up for an epidural or any kind of pain management, with medication, they can try these non-pharmacologic comfort measures. Again, acupuncture, acupressure. I've never seen that one used, but I'm assuming in other cultures they probably have utilized that. On the other hand, there are some things we can do involving medications and anesthesia. So intravenous medications, sedatives, hypnotics, analgesics are used. Usually we prefer to give those earlier in labor because they have a very limited time for administration. If you give it later in labor and the baby delivers soon after, get ready to have some Narcan on board, because whatever mom experiences from the medication, the baby is going to have the same effects. And our baby may not be breathing. So again, that's why they prefer to give a little cocktail. Usually it's Stadol and Phenergan IV push. They usually give that at the beginning. Now, it doesn't take the pain away. We always have to tell the patients that it works quickly. It goes right into the vein, but it wears off quickly, and it doesn't take the pain away. It might kind of distract them a little bit, but it's not going to take the pain away completely. And there's limited use. So local anesthetics is another thing, a paracervical block, infiltration of the perineum. Usually the local anesthetics are used more after delivery when we're repairing tears or episiotomies, or, we needed to use sutures. Even with an epidural, sometimes they will use local anesthesia on mom's perineum because sometimes, those areas are very tender. And if the epidural starts to wear off after delivery, then, she'll be nice and numb where they were suturing. So we do tend to use local. Regional anesthetics, this is your epidural, which is an option. We also have spinals, okay? And then we have a thing called a combination spinal epidural. So we know this about an epidural. First of all, before you give any of this, you need to have an IV preload available for the patient. So if your patient has some kind of cardiac issues, or she's hypertensive, or she's got preeclampsia, you may limit your bolus, your preload bolus, to maybe 500 milliliters, and then just assess the patient. Usually if the patient's not at risk, everything's great, she's pretty healthy, we give them 1,000 milliliter bolus of lactated ringers, okay? We load them up because what happens is these regional anesthetics tend to, in order to take care of the pain, manage the pain, it works on those nerve endings. And when it works on the nerve endings, it vasodilates the vessels. And when it does that, we kind of anticipate that drop in that blood pressure. So we don't want it to drop, because once it drops, remember that baby can't get that full oxygenated perfusion from mom, from her placenta. So we kind of anticipate that. So we want to load mom up with some fluids, with a bolus, to compensate for that drop, okay? Now, epidurals are great because they last a long time, but the drawback is that they take longer to work. But they do last longer than a spinal, okay? And you know, the spinal works very quickly, but doesn't provide pain relief for long periods of time. So, you know, if you got a doctor, I know at Lakeside when we work with residents, a C-section that should take 45 minutes could take an hour and 45 minutes. So they tend to give, you know, the epidural, or they'll do a combination spinal epidural where they put it in, it works fast, and it lasts long because we need them to stay, you know, with anesthesia a while. But if you got a surgeon that's 45 minutes, lickety-split, he gets in there and he does a C-section and he gets that baby delivered, a spinal is perfectly fine because that patient will, you know, the pain is going to be gone right away. There's not going to be any issues. It's going to start working as soon as it's put in, and it's going to wear off in like, you know, no more than like an hour. It starts to wear off. But the combination spinal epidural is really great because it works quickly. We can do the spinal and inject with the spinal, and that works quickly. And by the time, and that we can go ahead and put the epidural in next, and by the time that spinal starts to wear off, that epidural kicks in, okay? And it lasts longer. So it's a real nice cocktail as far as regional anesthesia goes. Again, the biggest thing is watching mom's blood pressure because even patients that we give 1,000 milliliter bolus, sometimes they need a little bit more of fluids, and if we don't want to overload them with fluids, we can give them ephedrine, which is like an epinephrine type. It's a vasoconstrictor, and it helps to keep the blood pressure in check. All right, so induction of labor. There's different indications. I'm not going to go through all of them, but on page 246 in the text, it kind of goes over that. Induction, we know there are risks. It's not performed without consideration of the maternal fetal status. And remember I said, we just can't give a patient the go to get induced. You know, 39 weeks, yes. But prior to that, in the OB law regulating world, it has to have, you have to have a medical necessity or a medical reason to do it earlier. So, because if you do it earlier, and remember that cervix is not quite ready, you can possibly set your mom up for a C-section. And C-sections, again, who wants a C-section? When you can deliver from below, the recovery time's better, it's easier to recuperate and handle the baby and all of that. But so again, we have to consider that. Studies are showing that with the rise in C-sections over the last 2 decades, medical management of labor is commonly practiced. Usually the patient is admitted with complete cervical effacement, dilation, artificial rupture of membranes can occur, or an amniotomy, and the administration of oxytocin. So usually it kind of goes like this. I mean, at Lakeside, our patients come in like 8 p.m. the night before, okay, and they're given a Cytotec tablet. And believe it or not, it's a tablet, but it does go in the vagina. It's not the whole tablet. They usually give a half a tablet. And that softens, it's a cervical ripening agent. It softens the cervix, and they can get crampy with it, but it will soften the cervix and make it more inducible. Okay. And then like 5 a.m. that morning, the next morning, they'll start the oxytocin, drip, you know, and that's how the whole induction will go. Natural induction is a term that we use. There's certain things you can do to get labor up and running, okay? A lot of patients that come in and they're in like active labor, we'll ask them, you know, what was their last exam? You know, what did the doctor have? And they'll say, oh, I went yesterday to the office and the doctor did a very vigorous exam on me. And it's kind of like they strip the membranes. So it's a very vigorous exam where there's a lot of, maneuvering with the membranes. And we call it stripping the membranes, which makes those membranes more prone to break or bust, and they break their water. Nipple stimulation, as we talked about with the contraction stress test, if you touch the nipples, any kind of stimulation to the nipples can cause the natural oxytocin to be released in the body and will start the contractions. Intercourse also, of course, make sure it's cleared with the doctor. But intercourse, the sperm contain prostaglandin, which works on the cervix and can cause some contractions. So those are natural ways to be induced without medication. The mechanical induction uses a Foley balloon catheter. We call it a Cook's balloon. And what happens is the patient may be a little dilated, but not a whole lot, and we might want to help her along and try to stimulate that cervix to open. So they'll put a Foley balloon in there, or Cook's balloon they call it, and we'll blow up that balloon, and it puts a lot of tension on the cervix and helps it to possibly stretch. So that's a mechanical type of induction. Medical induction, like we talked about a little bit ago, Cytotec 25 micrograms. The tablet is placed in the vagina, in that cervical area. The use of oxytocin. Prostaglandins is also something they used to use, Cervidil and Prepidil gel. It's a jelly that they shoot into the cervical area as opposed to the tablet. But studies have shown they don't use that as much because the Cytotec is so much more cheaper and it's economically, used for the hospital. So I haven't seen the Cervidil and the Prepidil gel in a while, but they do use a cervical ripening agent with the oxytocin. Bishop's score is how inducible is that cervix. And they look at the effacement. They look at the station of the presenting part. They look at the dilation. And it's called the Bishop score. And you have to meet certain criteria in order to possibly be, successful with an induction. So if you look at page 247 in the text, table 8-1, we'll talk about the Bishop score more in depth. VBAC. We kind of talked about this a little bit in another lecture, but a VBAC is a vaginal birth after cesarean, or you might hear it expressed as a TOLAC, a trial of labor after cesarean. Who are candidates for this? Okay, previous C-sections with a low transverse C-section incision. So somebody that has like the small bikini cut, okay? Remember, there's a skin incision and there is a uterine incision. So we go through layers of tissue, and then once you get to the uterus, you have to go through layers of that muscle. So you don't want to, you want to get somebody that has a small incision on the uterus. And it's, again, usually it's that bikini-like cut on the skin that kind of, they start with that. You have to have, because again, if you have a big old incision in the uterus, then we put some oxytocin on and we're trying to get them delivered, or we let them have labor and they're contracting so hard that uterus can rupture because there's weakened areas where there was incisions from the C-section. So that's something we need to consider. An adequate pelvis. Remember, the doctor has to, realize that we have to make sure that that pelvis is adequate to pass that baby, especially if they were a C-section for a big baby previously. Sometimes babies get bigger and bigger, but not all the time. But you want to make sure that the pelvis is adequate and that it can accommodate the baby. No other uterine scars or uterine rupture. The MD also needs to be nearby during induction. Actually, I remember when I was at Baptist, I worked at Baptist Hospital previously, and we had to have, because we didn't have a lot of residents, But our doctors had to be in-house a lot of time if we were inducing somebody that was a VBAC, not just an induction, but just, somebody with, that's been a C-section previously. Anesthesia also needs to be nearby if we have to have an emergency C-section. So that's not usually an issue. Every OB unit usually staffs a anesthesiologist and a CRNA, a nurse anesthetist on each unit, just to have them nearby because we never know when we need them. As far as nursing assessments and interventions, lots of assessment, of course, even more than just the regular induction. What are you looking for? You're going to look at vital signs. You're going to look at hemorrhaging. You're going to look at that monitor like a hawk, that baby monitor, because if there's something going on where that baby's in jeopardy or it's having some distress because mom's uterus is ruptured or something horrible is happening, usually hemorrhaging, you'll see late decelerations. So interventions, you would do the interventions that you would take if you saw fetal distress. Having the doctor nearby, usually they determine what the outcome will be, but we always are constantly assessing and intervening when needed. Preterm labor and preterm birth, we kind of touched a little bit about this. Labor and delivery after 20 weeks of pregnancy, but before the 37th week of pregnancy, okay? 12% of births are preterm, and they result in the highest cause of infant morbidity and mortality. Patients that experience preterm labor with prior pregnancies are at risk to have it reoccur. So if you had it with your first or your second, you might have it again. Again, the body, the more you have, the more quicker things happen. So if you had, premature labor previously, maybe that cervix may not want to stay closed with that third baby or whatever. So causes of premature rupture of membranes with cervical insufficiency. So that cervix is not real reliable to stay intact. It wants to dilate. The placenta previa, where the placenta comes first, or an abruption where the placenta rips off the wall of the uterus. Okay. Distended uterus. You can have a distended uterus. Some uteruses are different shaped. Maternal infection can put them in preterm labor. A lot of time if people are in preterm labor or they come in thinking they're in preterm labor, we immediately do a catheter specimen to test for UTI. A lot of them have UTIs and that puts them in early labor. Abdominal surgery during pregnancy can put them in labor. Multiple gestation. So if you have more than one baby in that uterus and it weighs really heavy, it can get irritable and start contracting early. So multiple gestation. Fetal anomalies. So anything that's abnormal about this fetus could put you in preterm labor. Smoking, alcohol, and drug use while pregnant can also contribute and be high risk, to make them high risk to have preterm labor. Let's do this question here. Before we do that, let's talk about some things we can give for preterm labor. Okay, we can give breathing. I know I mentioned that in a previous lecture, or terbutaline, which we can give sub-Q up to 3 shots. Sub-Q, and we usually give it in the arm every 20 minutes as long as mom's pulse is less than 120. Okay, we can give that and hopefully stop labor, but we may not be able to do that. We may have to go to the big guns, which would be the magnesium sulfate. Magnesium sulfate is an IV infusion, okay? And it is a very strong infusion. And when a patient is on a mag sulfate drip, they're pretty much staying for them, at the hospital while they have this preterm labor. They're not going anywhere. We can't just give them magnesium and send them out the door. Like we can with the terbutaline. So when the magnesium runs, it's very, very closely titrated on a drip. Okay, it's always on a pump. It can affect the lungs because it's a smooth muscle relaxer, and the uterus is made up of smooth muscle, just like the lungs and the heart. So what it does is it quiets the uterus. It stops it from contracting because it relaxes the smooth muscle of the uterus. But it also relaxes the smooth muscle in the other areas too, like the lungs and the heart and everything else. So what we worry about with this is our lungs not, working. Okay, so monitoring, serious monitoring is going on. We're listening to breath sounds, respiratory rate. We're checking reflexes on the patient, like DTRs, deep tendon reflexes. We take the percussion hammer and we hit in the kneecap and hoping that she has some good reflexes, because if they're diminished or they're really low, it could be that she's getting too toxic on the magnesium. We also have, it's hourly INO with the urinary catheter. Everybody on magnesium has a Foley, and it's not just a Foley bag, but we have a urometer attached because we're looking at hourly output. We want to make sure they're having at least 30 cc's an hour output. And we do it like every 1 to 2 hours. We're in the room measuring that urometer. So you're doing a lot of close monitoring because this patient can go into respiratory arrest. They really can. So, we have to monitor them closely. Why is it important that they are urinating or excreting urine? It's because we want to make sure that they don't build up toxicity in the bloodstream, that they're excreting it through the urine, so that we don't want them to get toxic. All right. The client is receiving intravenous magnesium sulfate at 2 grams an hour to stop premature labor. The nurse determines that the most important nursing assessment of this client includes intake, output, level of consciousness, and blood pressure, pulse, and uterine activity, deep tendon reflexes, early urine output, and respiratory rate, intake and output, blood pressure, and reflexes. So if you're looking at the patient on magnesium, what is the most important thing that you would be doing? Which one would you choose? These are your priority assessment. Not that all the others are bad, but your priority. This is what is most important, okay? So if you answered letter C, deep tendon reflexes, hourly urine output, and respiratory rate take priority. We're not so much worried about the blood pressure. We're not so much worried about we do look at the level of consciousness. Don't get me wrong there. But as far as being the most important, it would be letter C. Again, premature rupture of membranes is when they break the water early. Again, we can do some testing and treatments. And again, we look at that nitrazine paper. We look at the ferning pattern on a slide. AFI, how much fluid is around the baby, the amniotic fluid index. Sometimes they'll put an ultrasound, the transducer on mom, and they'll look inside and see, well, you know what, there's not a lot of fluid around mom. She probably had some premature rupture of membranes. We want to monitor the fetus, groupie strep status, because if this patient gets kicked into labor and we know she's groupie strep positive, remember, they do this at 36 weeks, so she could come in 36 and a half weeks and still be preterm labor or preterm rupture of membranes. So if she's positive, then we may have to give some antibiotics if she's going to go into labor. And they may induce her, because she might be so far gone, like she might be 5 centimeters and she's just stuck at 5 centimeters and she's ruptured. We don't want this infection to get to this little baby. It's already going to be a little on the preemie side. We might induce this patient just to kind of get her delivered. And of course, temperature monitoring, because once they break the water or they rupture their membranes, we have to do temps every 2 hours on our patients, whether they're premature rupture of membranes or just regular rupture of membranes. The temperature needs to be monitored very closely with our patients. Prolonged pregnancy is pregnancy over 42 weeks gestation. There's risks involved: uteroplacental insufficiency, macrosomia, really, really big baby. The longer they stay in and bake, the bigger they grow. And remember, they gain most of their weight at the end of the pregnancy. So just like everything else, the placenta ages, the baby actually ages. A baby that is overdue, sometimes they come out looking like old people. Their skin is wrinkly, it's dry, it's peely. They're peeling. They have scaly little like skin. The soles of their feet are really crackly looking. So with everything else, they age, the placenta ages, and as the placenta ages, the vessels tend to calcify, and it doesn't perfuse, and it doesn't give the baby that perfusion with that oxygenated blood supply that it needs to continue to, get the oxygen and grow like it should in utero. So, we have to think about that, what can we do if we, again, want to leave mom go and just keep an eye on the baby? We can do the non-stress test, the NST, we can do the contraction stress test, and we can do a biophysical profile or a BPP on that patient. So there are certain things that we can do. Again, we're looking at whether the baby's getting oxygen and perfused efficiently with the placenta, and if it's still doing its job. Some selected complications of the intrapartum period. These are some, and I'm going to go over each one of them, but these are the list of them here. Malpresentation. Okay, so malpresentation is when the baby's not coming out like we thought it should. It should come head down. It might be breech. Or it could just be CPD, cephalopelvic disproportion. Mom's pelvis is not accommodating the baby. The fetus is too large to fit through the pelvis. This can be frequently associated with difficult labors or labor dystocia. Okay. Transverse lie is when that baby is assuming a horizontal position in utero. They're kind of laying, again, that sideways. Okay, that face presentation, fetal face becomes the presenting part. It's a mentum presentation, and like I had said before, that usually results in a C-section because the baby can't pass through that way. And then we talked about the different types of breech, with the presenting part being the buttocks, the feet, or even both of the feet. So these are just malpresentation. This baby's not like we thought it would. It'd be head down and, tiny enough to pass through. So malpresentation. Some operative vaginal devices or for vaginal birth, sometimes for vaginal delivery, and even in a C-section, they may use operative instruments. And this is the use of instruments to facilitate and hasten delivery of the infant when vaginal birth is anticipated. But like I said, we can also do this in a C-section. An example would be a vacuum extractor where they put like a little, it looks like a little cap on the baby's head, or like a little cone, and they pump it up, and the pressure, it builds up pressure and forms a suction. So it's almost like it's sucking to the baby's scalp. And when mom is having a contraction and she's bearing down, pushing, remember, we want the maximum force when we use these things because we want to get success. We ask her to push, and then we pump it up and pull. As she's pushing, we're pulling, okay? And it pops off sometimes. It tends to pop off. You can't use it more than 3 times, no more than 3 pop-offs. Some hospitals say no more than 2 pop-offs. But because you can give this baby a really nasty hematoma, okay, which we don't want to do. But, vacuum extractor is considered it assists, or it's an operative vaginal birth device or instrument that we can use. Forceps, we used to pull babies out with forceps. We used to, deliver, and then forceps marks, and they had some nerve damage from cranial issues, neuro issues. So we don't use them like that anymore. That's forbidden, okay? We do tend to put them on to rotate maybe the baby. If the baby's OP and we want to get them to OA to make it easier to slip under that pubic bone, or that baby's really, really in there, we kind of want to help pull it down a little bit, we can do that. But as far as pulling the baby out, I've had some really bad experiences. Like, I thought a doctor took a baby's head off one day. She was pulling so hard on with those forceps. So I I'm glad that they've governed that a little bit more strictly, because it is kind of scary. But these are some operative vaginal birth instruments or devices that can be used. Why would we use these? Okay, to expedite the delivery. We want to get it, on and get the baby delivered. For fetal distress, we might be hearing some non-reassuring fetal heart rate, and we might need to get this baby out quicker than what mom could push the baby. Maternal exhaustion. Mom is so tired, she's been pushing, especially our first-time moms, that it could take, they could be pushing for a long time. So we want to help them along the way. So we can assist them by putting these operative devices in. Inability to push due to profound anesthesia, like the doctors will say, why did they give this patient such a heavy epidural? Because she can't feel a damn thing. So again, if they have some really good anesthesia on board, they might not even feel the pressure to push. And sometimes that happens, and they'll have to back up the epidural, and they may use the operative vaginal device. Or to decrease the maternal exertion, because we know mom, especially our sick moms, that maybe have some chronic issues, we may not want to make them exert so much. So we plan to use these operative devices when she's ready to push, to decrease that chance of exertion on mom. Cesarean, delivery of the infant through an abdominal incision. Usually, again, the uterine incision can differ from the skin, but it could be the same, The skin incision types, there's a phanestheal, low transverse, or there's a vertical incision into the uterine body. So it could be a low vertical, or it could be the low transverse. And we call the low transverse, another name is a phanestheal. The uterine incision could be a low transverse, or a low vertical, okay, or a classical, where the incision is made in the upper uterine segment and it comes all the way down. It's a straight line down. It's almost like they just cut mom open, okay? These are usually done mainly in emergency cases, and we don't use or see these much more and, as often as we did. Sometimes we'll get some patients from other countries that will have this big old line down the middle of their abdomen, and we'll say, wow, you had a C-section, we noticed. What happened? Was this baby in distress? And yes, the baby was in distress. That's why I had to have an emergency C-section. It's just the easiest way to get the baby out, so they tend to make that big old cut, and that's that big classical incision. The classical incision is definitely not somebody we want to be doing a VBAC on, because they have a big old incision, right? Remember, previous C-section also, we really don't put the IUPC or the intrauterine pressure catheter in these patients, because it can coil up and it can bust through the uterine wall, wherever the scar might have been. Okay, so keep that in mind. Indications, why would we want to do a C-section? If mom's having fetal distress, maternal distress, or mom's systems are compromised, abnormal placental implantation or abruption, of course, that's emergent. If it's a placenta previa, cervical and vaginal abnormalities. So if we have a patient that had, we did have a patient that had some issues with her cervix. They thought it was cancer. They removed parts of the cervix. So she definitely was not going to have a vaginal delivery and needed to have a planned C-section. Fetal malpresentation, the baby's not fitting, it's breech. Cord prolapse, we talked about that a little bit last time, where the cord falls out prior to the baby being delivered. So that would be that would be a need for a C-section. True CPD, cephalopelvic disproportion. We know mom's pelvis is very tiny and she can't pass this baby no matter what. So we're going to plan a C-section. Prior classical, undocumented cesarean incision. So again, if they have a prior classical, they can't VBAC. They're going to be a C-section again. Sexually transmitted infections. Some infections, I've seen HIV patients deliver from below with no problem. They do it. They do them in C-sections too. I guess it's just doctor and patient preference, depending on mom's status. And then herpes, if they're not having an outbreak of herpes and they don't have any lesions, then they can do a vaginal delivery. But if the herpes, if they're in the middle of an outbreak or they have lesions, then they definitely are a C-section. So that's something, again, we have to assess with the patient. We talked about meconium-stained fluid. It's passage of fetal intestinal contents in the amniotic fluid. Can be green or brown colored, may be particulate. It could be thick, could be thin. So again, we want to assess our fetal status. And then, we might want to do an amnio infusion if it's real thick meconium to thin it out. Again, it's easier to suck out the lungs, thin fluid than being that thick meconium particulate with chunks of stuff, okay? So again, we got to monitor our fetal status and definitely want to make sure they don't aspirate it. The cord prolapse, umbilical cord prolapse. When we have the umbilical cord into the birth canal ahead of the presenting part. So symptoms, you see a pulsating cord noted outside the vagina, or it's noted in the vagina on a vaginal exam. A lot of times patients will call out and say, something fell out of my vagina. I don't know if it's the baby or the baby's coming. So you go in the room, you pull the covers down, and there's that umbilical cord. It's pulsating. It's just hanging out. And the first thing you do, maternal positioning. So if mom's got an epidural, we cannot get her in a knee chest position. So we want to put them in a Trendelenburg position, okay? Reverse Trendelenburg, should I say, okay? With the head down and the feet up to get pressure off the umbilical cord from that presenting part. We can also go in and do a vaginal exam, a digital exam with fingers, and hold the presenting part up off of the cord, okay? Kind of like, a digital exam, holding up the presenting part to get the pressure off, or tent off of that baby's presenting part. So it doesn't compress the cord, because as it's compressing the cord, she's going to have decels. And then, of course, we're going to have an emergency cesarean birth. If mom is able to get into a knee chest position, which I'm going to show you in a second, that's also an option that she can get in, and that kind of gets pressure off the cord too. It's almost like mom's on all fours. So as you can see, she kind of puts her butt up in the air, and she puts, she's on all fours, and that's relieving the pressure off of the cord. Or like I said, we can do a digital exam and hold that head up off the presenting, or whatever the presenting part is. Hopefully, if it's a butt, we got to do a section anyway. But you can see there's different positions. But mom can't have an epidural and have all this going on, because, again, we can't position her like this. She's numb from her waist down. So the previa, remember, that's when the implantation of the placenta is close to, or it's over the cervical os. One big thing with a previa, they're going to bleed. They might have some spotting, but it's painless vaginal bleeding. There is no pain involved. It's usually bright red, okay? And it might be found on an ultrasound examination that placenta is covering that cervical os. So teaching, of course, no vaginal exams. If anybody comes in and wants to do a vaginal exam on this patient, absolutely not. I used to tell the residents, don't you dare put your fingers in that patient's vagina, because her placenta is a previa. She's a previa. We don't want to go in and disturb that placenta, I would say nicely, but really, you don't want to go in there with that. So monitoring the fetus, and of course, monitoring maternal hemodynamic status, because if she's got painless vaginal bleeding, it may be spotting, but it might not be. She might be bleeding profusely. It could be, depending on how stimulated that placenta is and irritated it is, okay? It could be ripping in pieces, from the pressure of the baby and whatever. So hemodynamically, mom could be, in shock. She could, again, we want to monitor her very closely, and vital signs, all of that. So there's different types. So the placenta can cover it marginally, where the placenta barely extends to the cervical os. Placenta will partially cover it. That's a partial, where just a good chunk of it can cover, or the entire completely covers the cervical os, the entire placenta. You can see that's called a total placenta previa. So there's 3 different ways or categories of previa, depending on how severe it is. But these always end up, I've never seen a previa delivered vaginally, of course. They always end up in a C-section. Uterine rupture. Remember, they might have had some old scarring from a previous C-section, or they had a surgery that involved, cutting into the uterine wall or whatever. So any kind of tear or old scar can put them at risk for a rupture. Uterine hyperstimulation. If you have a patient on oxytocin, and remember, one big thing is not just 60 seconds in between contractions for the baby, but you don't want to have a hyperstimulated uterus that's contracting constantly, because what's going to happen is there's a potential risk for a uterine rupture. Some symptoms you will see with a rupture is fetal distress, loss of palpable contractions. You may not be able to palpate contractions because the uterus is busted open. Some nursing interventions, again, monitor the maternal fetal status. That would be watching that monitor, watching that mom, vital signs, and of course, listening to what she's telling you if she's feeling pain, because it can be very painful. You want to prepare the patient for an emergency cesarean birth. And depending on how bad the uterine rupture is, and if they can't repair it, they may have to remove the uterus and do a hysterectomy. So it just depends on the circumstances. Placental abruption. Remember, we said that's when the placenta tears off that uterine wall. It can just tear off. If there's a short umbilical cord and the baby's coming down, sometimes that can pull it off. Or it could be abdominal trauma. What better time that we see spousal abuse or domestic violence, these significant others kicking, punching in the abdomen, that would definitely cause that placenta to dislodge off the uterine wall. And also just impact from if you have a car wreck and or even just a small car wreck. If that steering wheel hits your abdomen, we always tell those patients to come in. We want to make sure everything's okay. We want to monitor you. We may want to do an ultrasound and make sure your placenta is still where it needs to be. So any kind of abdominal trauma or anything. Also, we have people that come in and they use crack or cocaine, drugs, anything that vasoconstricts. Even just a smoker is at risk for a placenta abruption. Drugs, definitely. I took care at Baptist. We had a girl, she was smoking crack, and she claims it was secondary smoke from the boyfriend, but we knew better than that. She was smoking the crack, and they were heading somewhere, and they were, she was doubled over in pain, and she was starting to hemorrhage and bleed out vaginally. So they stopped in at the hospital. She was unreferred. We didn't know anything about her, but we knew she was having an abruption, and rushed her into the OR and delivered that baby. So, a lot of things can put them at risk, and there's some, interventions that we need to do. Again, is hypovolemia and shock we look for, because this is profuse bleeding. It sometimes can be concealed, and you may not see outright vaginal bleeding. It could be internal. So you may not see bleeding, but she might be going into hypovolemia and shock. You want to monitor the fetal status. What kind of decels would you see here? Well, uteroplacental insufficiency, right? The placenta and the uterus are not communicating because it's being torn off the wall. So you would see late decelerations, and then assistance with the cesarean birth. But just to go back, that abruption is bleeding, but it's very painful. It's painful. Their abdomen is hard like a rock. It's a board-like abdomen. It's almost like it's contracting if you palpate. And what it is the uterus is contracting. It's trying to hold on to the placenta that's tearing off the wall. But it's like the patient has one big contraction that never lets up. And that's why it's so painful too. So, shoulder dystocia, okay? This is delayed or difficult delivery of the anterior shoulder. It's due to impingement on the symphysis pubis. Some of the symptoms are delay in delivery of the head, regression of the head and the vagina. So we call that a turtle sign. So what happens is this baby's big. It's got these big old broad shoulders. So it's trying to come down, and it's leading, it's trying to lead down the birth canal, and those shoulders kind of get stuck, okay? So what happens is they get low enough, sometimes the head can kind of show up a little bit, outside the vagina, and you can see it coming, and then all of a sudden it sneaks back in. And they call it a turtle sign, just like a little turtle when you touch the turtle on the head and it goes back in its shell. So you'll see turtling or a turtle sign. Sometimes we can help with shoulder dystocia and open up the pelvis wider by doing some maneuvers. And when we do this, it's called McRoberts. When we open up the pelvis as wide as we possibly can by pulling I tell people, pull your kneecaps all the way to your earlobes. And that opens up the pelvis at the widest angle to see if the mom can deliver the baby. And sometimes they can, sometimes they can't. And then there would be a C-section. But assess the infant for injury, of course. That's really important. So like after the baby's delivered, you want to make sure that they don't have any Erb's palsy and nerve damage. Sometimes they can't move one arm as opposed to the other. And it could be, again, nerve damage from the shoulder dystocia. So here's some positioning. Again, this is McRoberts maneuver. She's pulling her knees back, but they're not far enough. Usually it's really, really far back. And sometimes we got other people helping hold legs back just to get that pelvis to open at its widest angle. Now, we used to have this, and we could jump on mom's belly and do fundal pressure, but that's a no-no. That's another new rule that the obstetric, society has come out with. We cannot do fundal pressure, but you can do suprapubic pressure where you make a little fist over that pubic bone and help push that baby down and get those shoulders down and delivered. So suprapubic is okay, but no fundal pressure, okay? When I had people tell me, oh my God, the nurses used to just jump on top of my stomach and put their elbows in my stomach to get the baby out. That is old school. If you see anybody doing that, that's a no-no, and they shouldn't be doing that. The suprapubic pressure, McRoberts maneuver, these are all other things that we can do. The nurse monitors a client during vaginal delivery of a breech infant for which of the following as the greatest risk? Umbilical cord prolapse, intracranial hemorrhage, meconium aspiration, fracture of the clavicle. Okay, baby's breech. So probably think about the feet being first. There's a lot of room in there, right? What can slip down? If you answered A, umbilical cord prolapse. So another thing we wanted to stress to you, if you have a patient that's dilated, she's dilated, and the cervix, the presenting part is not at zero station or in that positive plane, and that baby's presenting part is floating above the cervix, if you let them ambulate and they're ruptured, if they have no water bag, they are very high risk for cord prolapse, okay? So it's contraindicated. If we have a mom in labor, she breaks her water, or they break her water to try and get the labor really going, okay? She is 2 centimeters. She's a -2, okay? And, she's not going to be able to get out of bed to go to the bathroom. We're going to have to put her on a bedpan because there's a lot of room between the cervical os and the presenting part, and she's dilated, and she's ruptured. So there's nothing holding that umbilical cord back. So it can easily slip out. So it's, something that you really need to think about. The nurse determines that fetal distress is occurring after noting which of the following signs: moderate amount of bloody show, pink-tinged amniotic fluid, meconium-stained amniotic fluid, accelerations of fetal heart rate with each contraction. So if you answered C, you were correct. When we see meconium-stained fluid, even if it's early in labor and she breaks the water and she's not going to deliver for a while, that's meconium-stained fluid. We know that that baby had some issues at some point in labor, that they have, a bowel movement in utero staining that amniotic fluid. So that's something, again, we would have to make arrangements. What are we going to do here? We need to have suction on the field. We need to have maybe our nurse practitioner there to look down with a laryngoscope and check below the vocal cords to make sure the baby doesn't aspirate, okay? And we don't want to stimulate the baby. Like we used to want the baby to be stimulated. You don't want to stimulate this baby right away because we have to make sure we get a good suction of that baby's nose and pharynx out and mouth, just to make sure that they don't aspirate. So here's some video links. I mean, they're not the greatest, but they're on YouTube. You might be able to see, how the baby comes down in the birth canal. It gives you some ideas. Hopefully you'll get to see a real birth in your clinicals. And if not, we do simulation. So, these are just some things that you can refer to. But this concludes my lectures, and it was a pleasure lecturing to you. If you have any questions or any, concerns, you can always email me. We can set up a time to meet if you need to meet with me. This, again, is my element. I love this. So you don't have to love it. Just know it enough to pass the test and pass for boards. But it was a pleasure, again, lecturing to you, and I wish you all the best of luck. Have a great day.